Hello everyone, this is Dr. Chandana Vishnatham. Today in this video I'll be talking about respiratory system for MRCP part 1 and part 2. The topic is pneumothorax. So let's go into the topic. So the recent one is BTS 2010 guidelines that we are following, and you need to have an idea about the risk factors and symptoms of pneumothorax, but most of them these things won't be asked in MCQs. The management will be asked in the MCQs. So the risk factors include any pre-existing lung disease such as COPD, asthma, cystic fibrosis, lung cancer, um, any connective tissue diseases such as Marfan syndrome. They present with recurrent pneumothorax and rheumatoid arthritis, and any catamenial pneumothorax, which is spontaneous pneumothorax, which occurs in menstruating women. So catamenial pneumothorax can be one thing, and patients on ventilator or non-invasive ventilation are at an increased risk for pneumothorax as well. So the patients usually present with shortness of breath, sweating, chest pain, and increased heart rate. So these could be the symptoms of presentation, and the onset of the symptoms will be obviously acute. So, so this is important. Management of primary pneumothorax. Coming to primary pneumothorax, it is nothing but pneumothorax spontaneously occurring in a patient without any pre-existing lung disorder. So in the question, you need to decide first if it is a primary pneumothorax or secondary pneumothorax. So if there is a previous history of COPD or cystic fibrosis or something like that, uh, then you can suspect a secondary pneumothorax, but without any underlying lung disease. If the underlying lung is normal, but the patient had a spontaneous pneumothorax, in that case, you have to follow the guidelines for primary pneumothorax. So in primary pneumothorax, they can give you two scenarios. In first scenario, the rim of air is less than 2 centimeters. This is the first one. So the rim of air is less than 2 centimeters, and the patient doesn't have any symptoms, like there is no shortness of breath or chest pain. So then consider the patient for discharge. And there is a second scenario where the rim of air of pneumothorax is greater than 2 centimeters, or the patient has symptoms, shortness of breath or chest pain. So in both of these cases, if either the rim of air should be greater than 2 centimeters, or the patient should have symptoms. If one of these two is positive, then consider the patient for aspiration, and reassess the patient after aspiration. And if the aspiration has failed, that means if the rim of air is still greater than 2 centimeters, or the patient is still short of breath, then consider inserting chest drain. And advise the patient to avoid smoking, as smoking has been shown to increase the risk of pneumothorax in patients who have a history of spontaneous pneumothorax. So this is how we manage a primary pneumothorax patient. So whenever you come across a MCQ of pneumothorax, first check if it's primary or secondary, then check if it's less than 2 centimeters or greater than 2 centimeters, and if the patient is having symptoms or not having symptoms. So these three things you should keep in mind while answering an MCQ of pneumothorax, and then go ahead with either discharge or aspiration or inserting a chest drain based on the scenario that is there in the MCQ. So coming to secondary pneumothorax, that is the patient is having an underlying lung disorder. In that case, there can be two scenarios which can be asked in MCQs. And in scenario one, there is in turn two things, because this scenario one is less than 50 years patient with less than 2 centimeters rim of air and no shortness of breath, that is no symptoms are there. And in this less than 2 centimeters, they have divided it into two things. The first one is 1 to 2 centimeters, and the second one is less than 1 centimeters. This is very small pneumothorax. So as the pneumothorax is very small, give oxygen and admit for 24 hours, because the patient is having secondary pneumothorax. Remember that all patients of secondary pneumothorax should be admitted for 24 hours at least. So admit and give oxygen, even if it is less than 1 centimeter, which is very small. But the patient is secondary pneumothorax patient, so he's at risk of further pneumothorax. So it's better you admit the patient and give oxygen. And then 1 to 2 centimeters, consider for aspiration. If you remember in the primary pneumothorax, we have aspirated if it is greater than 2 centimeters or the patient has symptoms. But in secondary pneumothorax, even for 1 to 2 centimeters, you have to aspirate. And if the aspiration fails, you have to even consider for chest drain placement. That is, if the pneumothorax is still greater than 1 centimeter after aspiration. And in the second scenario, greater than 50 years old, and the rim of air is greater than 2 centimeters, or the patient is having symptoms, then directly go ahead with inserting a chest drain. So in question, look for symptoms, look for rim of air, and look for the age in secondary pneumothorax. So you can be confident enough to answer the MCQ. So admit all patients with secondary pneumothorax for at least 24 hours. And diving is permanently avoided unless the patient undergoes bilateral surgical pleurectomy and has a normal lung function in CT chest post-operatively. So this is also important when you advise the patient regarding diving. And some indications for chest drain could be pleural effusion, pneumothorax, but some cases can be managed by conservative management of aspiration, as I've discussed previously, and empyema, hemothorax, hemopneumothorax, and chirothorax, and penetrating chest wall injury in ventilated patients. And after you place a chest drain in a patient with pneumothorax, not only pneumothorax and any other patient, you need to confirm the position of the chest drain. It is usually inserted in the fifth intercostal space in the mid-axillary line under ultrasound guidance by a Seldinger technique. So you can confirm the position by aspirating the fluid from the drain tube and by swinging of the fluid within the drain tube when the patient inspires or on the, and you can also confirm the position on chest X-ray. So confirmation is important. This is not been asked in the MCQs, but it's just that you have to have an idea which can help in your clinical practice. And the relative contraindications are INR less than 1.3, platelet count less than 75 lakhs, and pulmonary pleural adhesions. If these are there, there are relative contraindications, but in an emergency situation, you have to deal with an individual basis, which is different. Like the individual patient is different, and even if these are present, that is not an absolute contraindication. It's just a relative contraindication. And the complications of chest drain insertion could be failure of insertion, bleeding, infection, and penetration of the lung. And the important thing here you have to remember is re-expansion pulmonary edema. So when you put a chest drain and the drain of fluid is coming out, and you will notice that the patient had an onset of cough, shortness of breath after the drain fluid has come out. So in that case, suspect re-expansion pulmonary edema, and the chest drain should be urgently clamped, and you do a chest X-ray to see if there is any evidence of pulmonary edema. So make sure the drain output is less than 1 liter in 6 hours, which is done to prevent the occurrence of re-expansion pulmonary edema. So these are the complications, and when to consider removal of the chest drain. So it depends mainly on the reason why you have inserted the chest drain. So if you have inserted the chest drain for the fluid drainage from the pleural cavity, so the drain should be removed from when there is no output for greater than 24 hours and imaging shows the resolution of fluid collection. But in cases of pneumothorax, the drain should be removed when it is no longer bubbling spontaneously, or when the patient coughs, and ideally when imaging shows resolution of pneumothorax. Obviously we have to considering all of the chest drain. And in case of penetrating chest injuries, they should be reviewed by a specialist to confirm an appropriate time of removal. So here is an example of an MCQ. So this 60-year-old man came to the emergency with the sudden onset of severe right-sided pleuritic chest pain, shortness of breath, and he's a smoker. And on examination, his looks unwell, and he's pale, sweaty, and the respiratory is 120, respiratory rate is 30, pulse rate is 120, and his saturations are 88 on room air. There is reduced expansion, reduced breath sounds on right side, and heart sounds for normal. Abdominal examination is unremarkable. So everything in this case is suggestive of a sudden onset, acute onset pneumothorax. And the EBG is done, which shows hypoxia, and chest X-ray shows 3 centimeter rim of air, and which is suggestive of pneumothorax. So as I've told you, look at the age, which is 60-year, and look at the symptoms. The patient is having symptoms, right-sided lower chest pain and shortness of breath are there. Symptoms are present, and it shows 3 centimeters rim of air. So this is more than 2 centimeters, obviously. And one more important thing here is with the known emphysema. So there is an underlying lung disease. So obviously this comes under secondary pneumothorax. And if you can remember, if you can recall, in secondary pneumothorax, if the age is greater than 50 years, and if the patient is having symptoms, or the rim of air is greater than 2 centimeters, everything is there in this patient. So you can confidently go ahead with answering insertion of intercostal chest drain. So this will be the answer. So in this Mrcp exam, you'll be asked questions on pneumothorax, something similar to this MCQ. It is not that this only comes in the exam, but they can give you another age, and they can give you a primary pneumothorax. They can give you a patient who is lacking symptoms. They can give you a scenario with the rim of air less than 2 centimeters or even less than 1 centimeter. So they can modify the MCQ, and they can give you different clinical scenarios in the MCQ. So in that way, you have to assess the MCQ and then go ahead answering the question. So this is how you answer the questions on pneumothorax. And yeah, my upcoming videos will be on these topics. So if you like my teaching and like my videos, please subscribe to my channel, like and share my videos, and encourage me to do more videos on Mrcp, which is very much helpful to people to make their exam pathway easier, and it can help people to pass easily. So please like, share and subscribe my videos. Thank you.